Hello students, today's topic is on inguinal canal. Inguinal canal, it is an oblique passage which is an intramuscular slit which is approximately 3 to 5 centimeters. Superolaterally it extends from the deep inguinal ring and extends anteriorly till the superficial inguinal ring. So the opening of the deep inguinal ring occurs at the medial half of the inguinal ligament or Paupart's ligament. So that is called as midpoint of inguinal ligament. So the midpoint of inguinal ligament, it is between the anterior superior iliac spine laterally and medially till the pubic tubercle. So the midpoint between the anterior superior iliac spine and pubic tubercle is the midpoint of inguinal ligament. Please note that there is a difference from mid-inguinal point. The mid-inguinal point, which is a midpoint between the ASIS and pubic symphysis. So from ASIS till the pubic symphysis, the midpoint would be somewhere here, would be the mid-inguinal point. So not to get confused between the mid-inguinal point and midpoint of inguinal ligament. So what we are saying is the midpoint of inguinal ligament, which is related to deep inguinal ring. So the deep inguinal ring is also found around 1.25 centimeters above the mid-inguinal point. So in this image we can see the location of deep inguinal ring. So deep inguinal ring, it is an aperture where we can see the contents. The spermatic cord comes out from the superficial inguinal ring. So this opening is the superficial inguinal ring. Where we can see the spermatic cord comes out through the superficial inguinal ring in males, and in females it is the round ligament of uterus. So next is points to ponder mid-inguinal point. Halfway between the pubic symphysis and anterior superior iliac spine is the mid-inguinal point. So the halfway between ASIS, that is the anterior superior iliac spine, pubic symphysis. This is pubic symphysis. So the mid-inguinal point is the midpoint between them. And the midpoint of inguinal ligament, that is the halfway between the pubic tubercle and anterior superior iliac spine. So it is still the pubic tubercle, means still here is the pubic tubercle where the inguinal ligament attaches there. So the point between these two points is the midpoint of inguinal ligament. So the opening of the deep inguinal canal, that is the deep inguinal ring, is located just above the midpoint of inguinal ligament. So above the midpoint of inguinal ligament, the oval shaped opening would be the deep inguinal ring. So here is the deep inguinal ring. So let's talk about the superficial inguinal ring, the medial opening of the inguinal canal. So it is a triangular opening which is present within the Hasselbalch's triangle, is known as superficial inguinal ring. So here we can see that an aperture in the external oblique muscle is the superficial inguinal ring, through which we can see the contents of it coming out, that is the contents of inguinal canal coming out, like spermatic cord in males and round ligament in females. So here this aperture is the superficial inguinal ring. So the side walls of superficial inguinal ring are formed from the crura of external oblique known as lateral and medial crus. So the external oblique muscle, it makes a crura on each side called as lateral and medial crus. So this superficial inguinal ring has got the lateral and medial crus which is formed by the external oblique muscle. So lateral crus attaches to the pubic tubercle. So the lateral crus attaches to the pubic tubercle and the medial crust is inserted at the pubic crust. Deep inguinal ring. The opening of the inguinal canal is referred to as deep or lateral inguinal ring, and it is located at the midpoint of inguinal ligament, and it is lateral to the inferior epigastric vessels. So this deep inguinal ring lies lateral to the inferior epigastric vessels. It is an oval defect in fascia transversalis. So the deep here the fascia is the fascia transversalis. It is the sagittal section showing the contents of the inguinal canal and also structures forming the roof and the posterior wall of the inguinal canal. So we can see the fascia transversalis through which this aperture is seen, which is called as deep inguinal ring. So the deep inguinal ring is significantly larger in males than in females because it accommodates the passage of testis into the scrotal sac. So during the descent of the testis has to pass through the inguinal ring, deep inguinal ring, inguinal canal and superficial inguinal ring to reach the scrotal sac. So that is the reason the deep inguinal ring is significantly larger in males compared to females. So let's see the boundaries of the inguinal canal. The inguinal canal has 4 boundaries: the roof, floor, anterior wall and posterior wall. So the roof is formed by internal oblique and transversus abdominis muscle. So the roof is here. This is external oblique muscle, which is continuing as the inguinal ligament, forming the anterior wall and floor. And this muscle is the internal oblique muscle, and deep to internal oblique is the transversus abdominis muscle. So internal oblique and transversus abdominis muscle forms the roof or the superior boundary of the inguinal canal. Anterior wall, it is derived from the aponeurosis of internal and external oblique muscle. So here is the external oblique muscle continuing, and we can see the internal oblique muscle also blends with the aponeurosis of external oblique muscle. So this forms the anterior wall. So the anterior wall, it is formed by the aponeurosis of external oblique and internal oblique muscle together. The floor, it is formed by the inguinal ligament and lacunar ligaments. So we can see the reflection of external oblique muscle. So this is the floor, which is formed by the inguinal ligament, the grooving of inguinal ligament. Posterior wall, it is formed by the conjoint tendon and fascia transversalis. So we can see the fascia transversalis, and deep to fascia transversalis is the extraperitoneal connective tissue and parietal peritoneum. So this is the fascia transversalis, and we can see the conjoint tendon forming the posterior wall. Let's see the contents of inguinal canal. So here is a schematic image for us to understand the contents of inguinal canal in males. Actually, the contents of inguinal canal vary between males and females. Ilioinguinal nerve, which is arising from the root value T12 to L1, which is present in both males and females, is a content of inguinal canal. And ilioinguinal nerve does not pass through the deep inguinal ring. It enters the canal by piercing the roof in the midway along the length of the canal. So ilioinguinal nerve, it pierces the roof and enters the inguinal canal on its midway. So ilioinguinal nerve provides the general somatic afferent innervation to the anterior perineum medial part of proximal thigh. It also innervates mons pubis, labia majora in females, and base of the penile shaft, the anterior scrotal sac in males. The next nerve is genital branch of genitofemoral nerve. So, genital branch of genitofemoral nerve arising from spinal segment L2, that is the second lumbar spinal segment, and it is present in both males and females. So, genital branch of genitofemoral nerve provides general somatic efferent supply to cremasteric muscle in males and general somatic afferent to the labia and scrotum. Labia in females and scrotum in males. And next most important content is the spermatic cord in males, and females it is the round ligament. So the round ligament of uterus, it is otherwise called as ligamentum teres uteri, passes through the inguinal canal to insert into the posterior surface of labia majora. In males, the male inguinal canal accommodates the spermatic cord. So the layers of spermatic cord are the external spermatic fascia, which is arising from external oblique aponeurosis. So this is external oblique aponeurosis, which is continues as external spermatic fascia. Cremasteric fascia, which contains the cremaster muscle arising from internal oblique muscle and its aponeurosis. So this is internal oblique, which continues as cremaster muscle and fascia, and internal spermatic fascia arising from transversalis fascia. So the green color one is the fascia transversalis. This fascia transversalis continues as internal spermatic fascia. So let's see the contents of spermatic cord. The main content is the ductus deferens. So we can see the ductus deferens. So ductus deferens or the vas deferens, which is the continuation of epididymis, and epididymis is the continuation from the testis. So we can see the ductus deferens passing through the spermatic cord, and apart from that, artery of ductus deferens arising from superior vesical artery. So along with this red line is the artery, which is the artery of ductus deferens. Testicular artery arising from abdominal aorta. And it also contains cremasteric artery arising from inferior epigastric artery. And we can see the inferior epigastric vessels. Which is giving origin to cremasteric artery, and we can see the plexus of veins within the spermatic cord called as pampiniform plexus. And genital branch of genitofemoral nerve. It also contains genital branch of genital femoral nerve, which enters through the deep inguinal ring and passes through the spermatic cord. And apart from these structures, it also contains some lymphatics and sympathetic nerve fibers on the arteries and parasympathetic nerve fibers on the ductus deferens. So these are the contents of spermatic cord. Inguinal canal development. The canals form the pathways for the testes to descend through the abdominal wall into the scrotum. So they develop in female embryo as well as in male. So even though the ovaries, except in rare cases, so even though the ovaries do not enter these canals are existing in both males and females. So as the mesonephros degenerates, the gubernaculum or the ligament descends on each side of the lower poles of the gonads. So we can see the gubernaculum ovary or gubernaculum testis. In females it is gubernaculum ovary, and in males gubernaculum testis, which is a fibrous ligament, attaches to the lower poles of the gonads. And this fibrous ligament passes obliquely through the developing abdominal wall and attaches to the labioscrotal swellings, which forms the future scrotum in males or labia majora in females. Each process of layers of abdominal wall before it, and together they form the walls of inguinal canal. In male, they also form the coverings of testis and spermatic cord. The opening produced in the transversalis fascia by the processes is the deep inguinal ring, that in the external oblique aponeurosis becomes the external or superficial inguinal ring. So between the rings is the inguinal canal. So this is the development of inguinal canal. So in inguinal hernia, it is an abnormal protrusion of intra-abdominal contents through the inguinal canal. So here we can see the protrusion of intestines. So into the inguinal canal. Causing inguinal hernia. An uncomplicated inguinal hernia typically manifests as a mass in the groin with or without pain, which is called as inguinodynia. So inguinal hernia is one of the two different types of groin hernias. So in addition to the less common femoral hernia, it can be further subdivided based upon the anatomic location, that is the indirect inguinal hernia and direct inguinal hernia. Indirect inguinal hernia. Indirect inguinal hernias are more common of two types. They are caused by the failure of processus vaginalis to regress. So the peritoneal sac and potentially loops the bowel enters the inguinal canal via the deep inguinal ring. So here we can see the image where the intestines are protruding through the deep inguinal ring and they come out through the superficial inguinal ring. So this is called as indirect inguinal hernia. So the degree to which the sac herniates depends upon the persistence of processus vaginalis. So the large herniations are possible in which the peritoneal sac and its contents may traverse the entire inguinal canal and emerge through the superficial ring and reach the scrotum. And this indirect inguinal hernia can be classified into complete and incomplete. And in complete indirect inguinal hernia, the intestinal contents protrudes through the deep inguinal ring and comes out through the superficial inguinal ring. So that is a complete indirect inguinal hernia. In case of incomplete, the intestinal contents protrudes and it remains within the inguinal canal, somewhere halfway within the inguinal canal. In such context, it is called as incomplete indirect inguinal hernia. Next, about the direct inguinal hernia. In contrast to indirect hernia, direct inguinal hernias are acquired. Usually in adulthood it occurs, and due to the weakening of abdominal musculature. So the peritoneal sac bulges into the inguinal canal via the posterior wall and medial to the epigastric vessels. So via the posterior wall of the inguinal canal, it enters into the inguinal canal, and which usually lies medial to the epigastric vessels and can enter the superficial inguinal ring. The sac is not covered with the coverings of the contents of the canal. Incarceration, obstruction and strangulation of hernial contents are collectively referred to as complicated inguinal hernia. So here in this image we can see the strangulated abdominal contents turning its color. So the most preferable clinical diagnosis for inguinal hernia is ultrasound. Surgery is the only definitive management of inguinal hernia and can be performed as an open surgery or laparoscopically. A strangulated inguinal hernia is a surgical emergency. In patients with an incarcerated hernia with or without bowel obstruction, manual reduction of the hernia may be considered as a temporizing measure before surgery. The conservative management may be considered in a select group of patients with small uncomplicated inguinal hernia. So this completes the anatomy of inguinal canal along with its clinical aspects, that is regarding the inguinal hernia and its management. Thank you.